Good morning, everyone. My name is Steve Miller, and it's my pleasure to introduce the Nussbaum Lectureship today. Sam and Rhoda Nussbaum, who the lectureship is named for, have been phenomenal forces and friends for Washington University and Barnes Jewish Hospital for many years. Dr. Sam Nussbaum got his training at Stanford and then Harvard and was an academic endocrinologist, but he was also an extraordinary administrator and rose through the ranks to where he was running Partners Health Plan for the Harvard medical staff. We were lucky enough to recruit Sam to St. Louis back in the late 90s to be the first executive vice president and chief clinical officer for the newly formed BJC health system. Sam's passion was really about the role of physician leaders in creating healthcare for the future. He was passionate about policy, administration, and patient safety and care. And he created a program to train physicians to have an active role in shaping healthcare for the future. And I, Dr. Frazier, Dr. Lynch, Zimmerman, Dunnigan, many who went on to be leaders in the United States in healthcare, actually went through Sam's training course. Sam then left Washington University and Barnes Jewish Hospital to be the Executive Vice President and Chief Clinical Officer for WellPoint and then Anthem, the second largest health plan in the United States. So truly an advisor to regulators, legislators from the White House through the Senate to the state capitals, a real force in healthcare. His wife, Rhoda, was equally a force. She was a teacher at Fontbonne University, incredibly involved in advocating for the underserved in St. Louis and also for Jewish causes. One of the remarkable things they've done, though, has been taking care of Oak Knoll Park, which was near their house. They planted many trees there and actually helped pay for the renovations of the park. And I'll end by just saying this. We all benefit from the shade of trees planted by others. The Nussbaum family has planted trees both figuratively and literally, and so we all benefit from them. So it's a real pleasure to have the Nussbaum Lectureship. I'm going to turn this over for the introduction of our speaker this year.
Good morning, everyone. Thank you so much for being here. I'm Karen Joint-Maddox, and I have the honor of introducing our speaker. So Dr. Alan Kachalia comes to us with a WashU background, so not his first time in this room. He actually asked, is it still in Clapton? Alan is from Southern California, went to UCLA for undergrad, followed by medical school at WashU, his law degree at the University of Pennsylvania, and then residency and chief residency in internal medicine at University of Michigan. He was recruited to the Brigham to eventually be in charge of quality and safety of the Brigham, which is where our paths crossed, and 6 years ago was recruited to Hopkins to be vice president for quality and safety. Alan has been, I think most importantly to this group, really a force in exactly what the Nussbaum family has encouraged, which is to say physician leadership in making the care that we deliver safer, higher quality, and better for all. So it's a real privilege to have him with us today, and please join me in welcoming Dr. Kachalia.
Well, it is an absolute pleasure to be here today. As Karen mentioned, I graduated from med school here many years back, and it's just lovely to be back in this auditorium. I never thought I'd ever have the chance to speak in a setting like this. And there are so many people, and I won't go through them all, but I just, as I look around this room, I just want to say thank you to for being here. My anatomy lab partner, Rocky, who without which I would have failed anatomy without a doubt, is here today in support. See, she's nodding in agreement. And then we've got Dr. Frazier and Dr. Lynch, who were actually my attendings when I was a fourth-year med student here. And I'm sure they don't remember, but they both wrote letters of recommendation for me to get into residency when I was pretty much a mediocre med student, in all fairness. So I thank you both for all of this. And then, we've got people like Karen and Clay here who've been incredible advisors and made sure that I was staying on track through the years. And I just want to thank you all for being here. It's just absolutely wonderful to be here. I don't have any other disclosures. So what I want to talk today is about the issue of achieving excellence in quality and safety, and how do we get there? I'll start with a little bit of background for all of us, And then I really want to talk about what I think are the two linchpins, which are going to be culture and technology, and where I think we need to go. And I'll talk a lot about where we're trying to go at Hopkins and what we're doing there as well, and then tie it up with some conclusions. I do plan to leave some time for question and answer because I think this topic has not been without controversy. So I'd love to hear people's thoughts and have some debate around this. So a couple simple case examples. Can you all imagine there's a patient who gets admitted to your hospital and they have multiple medical issues, and this patient gets admitted for shortness of breath, is noted to have a low hemoglobin hematocrit, and gets diuresed for heart failure. But of course, the sepsis was missed that this patient actually had. The patient codes and has an outcome afterwards. Can you all see this? Just a show of hands. Can you see this happening here? Right. Can you see this happening elsewhere? Okay. Another example here, radiation treatment. A much more simple case. So we've got a patient who's scheduled to get radiation treatment for cancer. Somehow the doctors change, one goes on vacation or one goes away or takes a new job or something like that. Patient comes in for the continuing radiation plan, but only gets part of the radiation as planned. Can you see that happening here? Right? I love the honesty from this group. And the challenge in this field, I would argue, is this. When I put these simple case examples out there for everybody around the country or around the world will agree that they can see this happening in their centers. So how do we fix it? Now, I think most of us know that back in about 1999, the Institute of Medicine, what's now called the National Academy of Medicine, released a report to Error is Human, where they estimated about 48 to 98,000 patients were dying in US hospitals each year, and that was a result of medical error. Now, this report, most of us still don't know why, caught the attention of the public, caught the attention of the profession as well, and over the last 20 to 25 years, we've seen an incredible burst of activity in this space. Organizational structures have been changed. For example, my job 15 years ago didn't even exist. A whole new set of jobs and roles have been created to help drive quality and safety improvement. We now talk about how do we make the system better instead of blaming the individual provider. EHRs were supposed to be able to allow us to leverage technology to bring better clinical decision support. Measurement was going to deliver us, right? We needed to continue to foster a safety culture. And of course, the government also got into the act by posting our hospital data on the websites and actually attaching financial incentives to how we did. And I would argue this has all been welcome because it's going to take collective action for us to drive improvement. Yet when people go back and look at the data, it turns out moving the needle has proven pretty challenging. I'm not going to go into the details of these analyses here, but you can see that about 10 years after the report came out, they did an analysis of safety-related events or adverse events in North Carolina hospitals, and they didn't see a big change. Then in about 2018, actually when I was at Brigham, my boss was working on this analysis here. They hired a bunch of reviewers to look at about 2,800 admissions across 11 hospitals in Massachusetts and asked these reviewers, was there an adverse event that happened to a patient? Did something go wrong? Did the patient get hurt? And if the patient did get hurt, was it preventable? And what they found in this analysis, which was released about 2 years ago now, was that there was a serious preventable adverse event, again, a mistake that seriously harmed a patient, in about 1% of all hospitalizations, which wasn't that far from the IOM estimate of the injuries that were occurring in US hospitals. So many of us still talk about the fact that yes, quality and safety have gained more importance. It's definitely on the agenda, but how much of a difference have we really made is what we struggle with. And of course, after this analysis was conducted, we all know that COVID hit. The CDC had put data out showing that when you look at infections, so what this table shows is the observed to expected infection ratio across our country, so what they call the standardized infection ratio. Higher is worse. If you're at 1, you're where you're expected to be. You obviously want to be lower than 1. And what you can see for things like vent-associated events, MRSA, bacteremia, CLABSI, these numbers all moved in the wrong direction when the pandemic hit. There was a flurry of discussion around what to do around this, and I think a lot of people said, you know, it turns out the systems that we had built to improve quality and safety, the word was resilient. They did not withstand the stress that the pandemic had put on the healthcare system, and we saw numbers move in the wrong direction. We all do Google searches, and it turns out it's still not that hard. If you type in a Google search for medical error, you can still find a lot of stories about the challenge here. The one in the lower right corner right here is probably the more famous one that I'm sure you guys are aware of. A hospital here in the Midwest, a nurse wanted to give a patient Versed for somebody who was getting a CT scan, and she typed in VE into the Omnicell to go get Versed, and hadn't looked beyond the subsequent letters and gave vecuronium instead, which we all know is a paralyzing agent. The nurse was under a lot of stress, grabbed it, mixed it, did not stay with the patient after she gave the Versed, and ended up giving the patient a paralytic. And you can well imagine what happened when the patient couldn't breathe. She actually did code, and she actually did die afterwards. But if you ask most quality and safety leaders, could they see this happening in their hospital? They'll tell you that risk is still there. We still have a long ways to go. There's still too many stories of error. So that's the background there, right? This is the challenge that we're trying to deal with. What do we need to do? I think a lot of it has to do with getting back to some of the fundamentals. We need to go back and look at, you've heard all of these topics before, but I want to just show you the approach that we're pushing on to try to get us to where we need to get to. One is to set the right culture. 2 is to actually get better at measurement. 3 is to make it easier for our clinicians to do the right thing. Our focus has been on how do we make it so that something doesn't happen, but in parallel, we haven't made sure how do we make it easier for our doctors to do the right thing. And I'll give you examples of all of this as we walk through this. Culture. So we all talk about a systems approach here, and I will readily agree that it is easier said than done. So the example I always like to use is stop signs. We all know that stop signs are meant to stop cars from hitting each other and from cars from hitting pedestrians in the intersections, right? You see a stop sign, you're supposed to stop. How many of you have unintentionally, I won't even ask about intentionally, unintentionally run a stop sign? Heck, I got ticketed for it when I was a law student. I still remember this, and I didn't see it. And that is a challenge right there. We often put up stop signs in what we want to do in healthcare, full well knowing that people will accidentally blow by them. And we've got to find a way to make sure that that doesn't happen. On the flip side, we talk about what we call effective and resilient solutions, right? Either someone chooses to run the stop sign or misses it. How do you stop that from occurring? And you can see in this picture here, there's those poles that come out of the ground. The idea is if a car wants to get through it, if they miss the stop sign, they're going to hit the pole, but they're not going to go into that intersection. Undoubtedly a resilient intervention. But I think all of you can readily see what the challenge in that intervention is. If you had to wait for the bars to go up and down every day on your way to work, you're going to go crazy. And it's just not going to work. You're not going to accept the intervention. So our challenge in safety is this. How do we go from being effective to resilient? And it comes down to design. We've got to think much more about the human factors. We've got to have that emphasis on workflow. I'd argue too often we've just said, look, the safety is important. We haven't looked at the workflow on it. And of course, we have to consider the cost on these interventions. Now, what are the fixes in every case? I don't know. We're going to require a collective group of individuals to tackle these problems one by one. And why aren't we tackling them? I'd argue problem number one is this. We have a big issue with transparency still in healthcare. I'll give you a story, and then I'll give you some data to back that piece up here. I don't know if any of you heard about this story, but I'm going to make up the names. There was a hospital in southern Washington. There were 2 guys that lived together. I'll call them Dave and Tim, okay? Dave comes home one day and sees Tim choking on some food that Tim was eating. And Tim, unfortunately, passes out. Dave calls 911 like any good roommate would do, and the paramedics arrive, okay? They take Tim to the hospital because he needed to be taken to the hospital because he had passed out from choking. But Tim somehow didn't get registered under his own name. He got registered under the name of Dave, his roommate's name. Right? How that happens, I still don't know, but you can see it happening, okay? The hospital decides that Tim isn't doing well. I hope I got the names right. I hope I didn't mix them up here. Tim isn't doing well, but they, of course, call Dave's family, because that's who they think he is, and say, Tim's not well, we need to withdraw care. Dave's family, now I still also don't understand why Dave's family didn't come in before they withdrew care, but gave permission over the phone and withdrew care, and he passed away. Dave is hanging out, not knowing what had happened here. 2 weeks later, he calls his family and says, I don't know what's going on. They cut my cell phone service, my credit cards don't work, and everybody thinks I'm dead. Real problem, right, for this poor guy. So of course, they call the hospital, they sort it all out, and the hospital realizes that it made a mistake in who it had called. And the county had registered the death in the wrong person, okay? Because the name had just been wrong from the time the patient got admitted. What did the hospital do after that, once they fixed all the paperwork? Nothing. The answer is nothing, right? Now here's an opportunity for us to figure out, to make sure our registration systems, when people get admitted in a hurry, are working correctly, and what were the failures that occurred, but nothing happened. The story broke about a year later or 2 years later only because some investigative reporter was doing a report on this, and that's how it came to light. And there's the challenge in transparency right there. It turns out if you look at culture of safety results, I'm guessing you all administer a safety culture survey every 2 to 3 years, as you're required to do by the Joint Commission. Some do it more frequently. And what's here is you can send in your results if you send a validated survey to the government. They will compile the results for you, and you can actually go get these results off the HRQ website. It's a remarkably powerful tool in this regard. And what I've done is I've taken a few of the composite scores from the survey where we ask our employees, how do they feel about the culture? One of the questions is, do they have a positive feeling about feedback and communication when something goes wrong? Another one has to do with communication openness. How open is your hospital with regard to communicating? And of course, if you make a mistake, will you face a non-punitive response? You look at the positive response rates here, you can see that in 2007, the numbers weren't that good. Only 62% reported a positive response when it came to feedback and communication. 61% felt their hospital was open around error, and only 43% felt that they wouldn't be punished if something went wrong. What's great to see is if you look over the next 15 years, we've made positive strides with regard to the responses in our surveys and our culture here. Hospitals have moved in the right direction. Healthcare has moved in the right direction. But if you still look at that bottom corner, I still think that number is still problematic. Only about 63% of the time are people saying that they would face a non-punitive response to error when something goes wrong. And this is the challenge. If we want people to collectively work on mistakes, we've got to get them to talk about it. We've just got to do it. This isn't specific to healthcare, what I'm talking about, but it's very notable in healthcare, right? How do we get there? Well, I think there's a lot of us who believe that the solution is actually not to focus on getting our folks to speak up. Let's focus on talking to our patients about it, because it will drive all the other behaviors that we need to see in our medical center. So the concept is what we call communication and resolution programs. So what we've seen over the last 20 years is incredible attention to error, and we've seen much more calls for disclosure to support what we call to execute on our ethical obligations, and I'll talk about those too, and transparency, as I just talked about. Turns out if you survey patients, they'll tell you they want to hear about every mistake, even if it's little, like 20 versus 40 milligrams of Lasix, they want to hear about it. Most people believe that if you tell them about your mistakes, you'll have greater trust in your relationship. And of course, people like me believe it can go a long way in improving safety. But the big driver for me actually sits on this right-hand side as I try to drive quality and safety across our system here. Turns out when you sit down with a family and you apologize to them about what happened and explain what happened, what they will more often than not want to hear from you is, what are you going to do to make sure it doesn't happen to the next patient? I cannot tell you how many times the conversation, it doesn't go to, I'm going to sue you, I'm angry at you. They may be angry, there's no question, but the conversation almost always goes to, what are you going to do about it so it doesn't happen again? And I believe that if we can get our systems and our hospitals to routinely sit down and talk with patients about this, that's the way to make it happen. Now, these programs aren't new. They got their big push in the early 2000s when then Senators Clinton and Obama wrote an article, I don't know if they wrote it, but they were the authors of the article, in the New England Journal, talking about how they thought disclosure and offer, as they called it, was the way to improve patient safety. They were talking about Michigan's program at the University of Michigan, where I trained actually, where what happens is if a patient was hurt, notice I just said hurt, you set up a team that goes in and talks with the patient and says, we're sorry you got hurt. We're going to investigate. If it's our mistake, we will come back and tell you it's our mistake, but you don't stop there, right? Once you tell them it's your mistake, you make a commitment to go back to them and tell them, look, here's what went wrong. You then sit with them to tell them how you're going to fix it, and you also don't wait for them to sue you. You figure out how they're going to you figure out what they need to make them whole as you can, and proactively make them an offer of resolution. That's what these programs are all about, what we call communication and resolution programs. Now, they've gotten a lot of attention over the last 20 years. The two biggest barriers, I think, one are people just don't like to talk about their mistakes. And the other big one, because we live in America, is that everybody thinks that liability will go through the roof, and they say they're impractical. You can't implement them because people will just sue us. You're writing patients a blank check. Well, the folks at Michigan were kind enough to let us go in and take a look at their data on how they did. You can see that they'd implemented their program in 2001. They quickly realized, wait a minute, if we're talking about these errors much more openly, we should be tying them into our safety efforts, and it took them about 2 years to do that. But when you look at their claims experience before they implemented to how it looked after they implemented, and again, this is just an observational analysis, they had a 36% drop in claims. Here, everybody said you'd be writing people a blank check and you'd see many more lawsuits. Turns out you didn't. I will tell you, in parallel, what the university also started doing was they stopped settling what they called nuisance suits, because it turned out to be cheaper to settle some suits than it did to defend them. And the university said, no, we're taking a principled approach. Even if it costs us more to defend, we're going to do what's right. If we're wrong, we'll pay. If we're not, we'll fight. The principled approach. If you look at their costs, their legal costs, the amount they were paying their lawyers dropped by about 60%, and the amount they were paying to patients in compensation dropped by about 60%. And most of this was driven by the fact that they weren't seeing large lawsuits anymore. They were settling them out for what patients needed. People said this is one university, Ann Arbor's a closed system, they hire all their docs, it's a lovely place to work, you don't see that many lawsuits. I was lucky enough to be part of a team in Massachusetts where we had 2 big academic centers who wanted to implement these programs, and there were 3 big academic centers in our state that didn't want to implement these programs. So what we did was we implemented at 2 of them. The other 3, about 10 years later, were kind enough to give us their liability data as well as their clinical data so we could look at them as comparison sites. And what we did was we said, look, let's compare the sites that implemented CRP to those that didn't. And what you'll see here is that you don't see any worsening of liability outcomes in the sites that implemented. We saw some lower costs, lower claims at the community hospitals and one of the academic centers, and lower defense costs at the AMCs. How significant that was, hard to prove, but when you compared the trends, what was important to recognize out of all of this is that if you executed on your ethical obligation, you didn't see a worsening of liability outcomes. The CMS has caught on to this concept, I will tell you. I think in their new, although it could all change with the new administration, I readily recognize this, but they recently released new standards where they want hospitals to certify that they have a CRP program in place. Now, I will tell you, you will hear all kinds of issues about how difficult it is to do. The doctors don't know how to have the disclosure conversation. That's true. We worry about the liability risk. It's true. We don't know how to support our providers when something bad happens. That's completely true, too. I argue this is all secondary concerns. When you go to implement programs like this, let's stick with the ethics of it all, which is that we have an ethical obligation to tell our patients what happened in their care and how it happened. If you can stick to that concept right there, you will drive your CRP programs to where they need to get to, because everything else is secondary and needs to be managed. This is an article that I was lucky enough to write with Tom Gallagher. He was also actually a young attending when I was here. I think he had the pleasure of working with Dr. Fraser as well. He and I have in contact through the years. He's a bioethicist, as you can imagine. And that is what we argued. It's about when you look at the ethical framework, CRP should be based in the ethical framework. Everything else that we talk about, including, I would argue, the safety improvement, is secondary. These are all benefits that flow from doing the right thing. Now, I can say this, but what we've learned is building these programs is not that easy. It's not as easy as simple as telling your doctors, go talk to the patient and apologize, because they will look at you and say, what do you want me to do? They worry about throwing other doctors or nurses under the bus. They worry about the lawyers coming around and asking them, why did you say that? Right? What we've learned is you need to build a program. You have to build a program with leadership support and advocacy, program managers, protocols. It's important you get your liability insurer to buy in. I can tell you at Hopkins, that battle was much easier for us because our liability insurer has agreed to settle whatever we want to settle. It was very different for us in Massachusetts when we tried to build this, where our liability insurer wanted to make that ultimate decision on compensability. You need key physician engagement, and don't forget the peer support programs. But that is what we are striving to do. And I think this, when you get to the point where you're going to talk to your patients and tell them about what happened in their care, it drives all the other openness pieces that you need across your system. That's culture. So I want to talk about technology. We're all pretty lucky. I remember when I started med school what an MRI scan looked like and how I had to go get the film and what the films looked like and people read them. And over the last 20 to 30 years, technology with regard to robots, CTs and MRIs, the fact that we had a new vaccine in 9 months is still just absolutely unbelievable to me. Yet when you talk, right, and we take this for granted, yet when you talk to a lot of docs about technology, they often think about the EHR. I don't know about you, but my Epic implementation wasn't fun for me, and I still struggle with using Epic. And many of us say that, everybody thought the EHR was going to make life easier and going to take quality and safety through the roof. But I think most of us would readily agree that it didn't. And it has led to a lot of complexity, extra clicks, alert fatigue that we hear about, and it has not yet delivered the way it ought to. I'm hopeful, we'll come to that in a minute. I'm hopeful that we can change this. So let me talk about two places where I think tech can make a big difference. The first one is measurement. So I happened to be at Hopkins when COVID broke out. And of course, the folks there found out how to scrape data from everywhere things were being measured to create this dashboard as to where were the COVID hotspots. This, to me, was the incredibly perfect example of how measurement can help set policy, help us figure out how we're doing, and it was done beautifully. Yet, in parallel, at the same time, about a month, actually the same time the COVID outbreak got started, CMS announced, guys, we don't expect you, it's okay for all these quality reporting requirements we've put on you. It's okay if you don't report for the next 6 months because we know you've got important things to do. Now, I get why they did it because COVID was so important and we were all scrambling. But what does that say about our systems with regard to measurement if we're saying we don't need to measure where we're going? And it speaks to the fact of the way we've built our measurement systems. Right? We had an article about 2 years ago, folks at the Armstrong Institute. What they had done was they'd gone back at Hopkins and tried to figure out how many people hours and how many dollars were we spending on each metric. And we estimated that about $6 million a year was going to quality measurement alone. Just measurement, I'm not talking about the improvement activities. Whether the metric was one that was being taken off of claims data and being sent in anyways, because it turns out when you do that, hospitals will still spend time making sure that that bill was correct and the coding was correct because they want to be measured as accurately as possible, or whether or not it was just a chart abstracted measure like NSQIP type of data. $6 million a year, and you can extrapolate that cost across the entire US, and you can imagine it's a big number that we're spending in measurement, which is supposed to be fundamental to what we do. Now, you take your Starbucks app, those of you that purchase at Starbucks, I'm guessing they can tell you within 2 minutes how many lattes they sold 5 minutes ago. because they can track everything because they've built their measurement systems that way. We have not yet done that in healthcare. And I think this is where AI holds a lot of promise for us. So one thing that we are trying to do right now with the advent, and again, this just changed over the last year, with the advent of the large language models, we currently, to participate in our National Cancer Database in Maryland, we have to hire a team of abstractors who have to go through these detailed charts like this, figure out what the radiation dose was, how long was it, what was the outcome of it, and then once they find it in the chart, they have to go enter it into a different database, introducing, of course, abstraction errors. This is how many hospitals still perform quality measurement today and report it to the state. We're in the process, I can tell you, of trying to figure out how do we leverage large language models to pull this data out, offer it to the abstractor, saying, here's what I think the answer is, because the models aren't there yet. They still need to be trained. Offer this data to the abstractor, let the abstractor hit a button saying, I agree, and then just ship it over to the right website. So we're trying to get rid of those transcription errors at the same time and make this abstraction work easier. Our hope is that over time, what we will do is that we'll be able to train these machines, these algorithms so much better that they'll do the measurement by themselves, or even at baseline better than a human would do. That is where we're trying to go with this right now. And eventually, you can imagine once the models get good at this, there's no reason the metrics that we measure, we can't get more creative about asking the computer to measure things that are directly available in the chart that we wouldn't have been able otherwise to do. And the example that we're actually trying to do right now has to do with VTE prophylaxis. I drove my team crazy because I insisted I thought this would be the easiest proof of concept. It took me a lot of convincing, but we're in a partnership. Hopkins is in a partnership with Microsoft because what happens is that these big industries want to get into the AI world. It's the data access that's super important to them. So they've brought their tech expertise to the table. We have our data and our clinical expertise to the table. So what are we trying to do? We're trying to figure out how to automate VTE prophylaxis. This is a task that we know every doctor that admits a patient should be doing when they get admitted. VTE is still one of the most leading preventable causes of harm in hospitals. So what do we want to do? Get the computer to collect the risk factors. Most of our docs, it turns out when you look at where do the failings occur as to the preventability of VTE prophylaxis, it's all of these steps. It doesn't matter. Mistakes happen at all 5 of these steps are there. Trying to get the doctors to go through the chart and figure out what the risk factors are is complicated. Making the risk assessment, it turns out you can give somebody all the risk factors and then ask them to apply all the algorithms, and there's many different algorithms out there. Getting them to apply it to your hospital's algorithm isn't that easy. And even once they see it and the algorithm tells them to do it, they still don't always write the order. And then, of course, care changes while you're in the hospital. How do we get people to hold prophylaxis when they need to? And of course, turns out we're learning a lot of doses just get missed. A patient will refuse that extra dose of Lovenox in their belly because they just don't want it. The nurse doesn't think it's that big a deal because it's just one shot. But sometimes it'll happen over 3 or 4 days and the doctor doesn't check the medication administration record, and lo and behold, a patient gets a blood clot. So what we're actually trying to do, they're calling it a health general reasoner is what they're calling it in our partnership with Microsoft. What we want the computer to do is actually take the risk factors out, ask the doctor, do you agree or disagree with these risk factors? If the doctor agrees, apply the algorithm, make the order recommendation, and then monitor for them on how the prophylaxis goes. I am super excited about this because I really think this is a case where we are actually going to make things easier for the doctors to do by taking what most people consider to be a routine task off their hands. And of course, we're trying to get more sophisticated about this too in parallel. I don't know if you guys, there's been a company called the OR Black Box. Have you guys heard about this, where they're putting cameras and audio capture in the operating rooms? Anybody familiar with that? Yes? A little bit? No? Well, the word today apparently is called ambient intelligence. So the idea is our computers and our cameras have gotten much better at measuring what goes on. And the best example I like to use is my car. When I drive today, my car is actually monitoring and checks to see if I'm in a lane. And if I start to veer out, it doesn't just alert me anymore, it actually turns the steering wheel for me. The other day, there were 2 cars coming out. I thought I could make it through the 2 of them. And I kept going with my 2 kids in the car. Don't tell my wife that part. And my car decided I wasn't going to do it and hit the brakes for me and made me stop. It just decided the risk wasn't worth it. And at the end of the day, I was thankful that the car stopped because who knows if I would have made it or not. It just wasn't worth it, okay? The ambient intelligence capabilities of our computers today are remarkable. But yet, this is how we still do quality improvement in healthcare today. We have the medical encounter. It could be the operating room. It could be the ED. It could be the primary care clinic. The information goes into the electronic health record. People do some post hoc analyses. That's how we do research today. And then we lead and try to implement improvements. There's no reason today you couldn't figure out a way to capture data real time. Put the cameras up, put the audio up, and have the computer in parallel, like physiological data. I argue we should also be capturing how patients and families feel. So the best example I can use is in the sepsis cases when it's missed. You will often hear families telling you, we were worried, but our doctors weren't listening. We've got to find a way to get that sentiment into our analysis real time. And you can do that with these algorithms, right? With AI today. You do some data processing, and what you can do is in real time, you can create a command center that takes these alerts when they trigger, because they're not going to be good the first time you put them out there. And if you put them in front of the doctors, nobody's going to accept them, and you're going to have that decision fatigue again. So create a command center that is saying, yes, I think something's wrong here, that can phone into the doctors and say, would you please take a second look? And eventually the algorithms will get good enough that it'll become automatic, but you need to train the system and provide that second look. We actually just are in the process of signing a contract with a company where we're going to put cameras in the ORs, capture the audio feed so that we can do this type of improvement real time. Because we believe that our clinicians will accept the real-time help if it's delivered in the right way. And to me, I analogize, we all welcome that help from our car when it stops us from veering out of the lane. Now, I say this, but I want to be clear. Implementing it won't be easy, and there are a lot of challenges, and I just want to take a few minutes to talk about some of these challenges because they are important. One is building that infrastructure. Turns out buying the cameras, getting the audio capturing tools today, super inexpensive. It's training your models and hiring the programmers that are going to cost you a lot of money, and the data storage is what's expensive, so we're trying to sort that through. The patient and staff consent is the other big one. Some states, you need both parties to consent to audio capture because of our historic wiretapping laws, and I actually think those laws are correct for what it's worth. But we've got to find a good way that people understand that they're consenting to having their images captured and being stored. Especially because when you think about it, when you're in the operating room, you're pretty vulnerable and there's a lot of exposure going on, which leads me to the biggest one. And this is the one I still worry about the most, is the cybersecurity risk. When you have these sensitive images, how are we going to promise our patients that we're going to keep them safe? So we're trying to sort through what's the way to do it. One way that we're thinking about it doing it is it turns out the cameras are so good today that it's called edge computing. They can capture the image and de-identify the patient right there as it captures them, so you're saving de-identified images in your system. But again, these are issues that we are still sorting through. The ethics and equity, as we've talked about, the algorithms can be biased. What do you do with regard to commercialization? Because once you develop a good algorithm based on this patient data, is it okay to market it to others? What kind of consent did they need upstream when you did this? Everybody worries about the discoverability of this. This, to me, is probably the easiest one. I always say, look, if we've already agreed, going back to the cultural piece, of telling patients what went wrong, why would you care if they had the film? And in fact, most people often argue they're suing us for the wrong reasons. We did everything wrong, did everything right. Now you have the images to prove it. So I'm not worried about that one. But the bottom one is the one that, again, it comes back to the whole cultural piece that I still worry about a lot, which is your employees need to trust that you're going to manage them fairly with the data that you capture. Are you going to police them that they were in the bathroom too long? Or are you going to come down on them when they made a mistake that any person could have made? They need to know that you're thinking about this from a systems approach, and you're not going to use this data real time to monitor them or manage them or punish them. And this goes back to the cultural piece that I talked about. You've got to get that safety culture right. So as much as we want tech to come, and I think it's here to come, Where the real work needs to be done is in these items here, and that is where our focus has been in setting up groups to figure out how we're going to do this across our system here. Again, it hasn't stopped us because, as I mentioned, we're in the process of installing the cameras and the audio in our operating rooms at one of our community hospitals. Now, just a word on tech, as I mentioned, I used to put up slides of the aviation industry, but I just decided, given the recent events, that nobody wanted to see the images of Boeing, right? Everybody remembers what an incredible culture of safety they had, and they had that door blowout. No matter how technical, how much technology you can have in your industry, and it was because somebody forgot to put in the bolts. In the New York Times a couple years ago, and I think it kind of portends to what we're probably going to learn about the recent event here in DC, there was a story where an air traffic control had cleared a FedEx plane to land, yet there was a Southwest plane sitting on the runway. As the FedEx plane came down, they saw the Southwest plane and pulled up at the last minute. The two planes at those speeds, this plane's speed, they missed each other by about 100 feet, which at those speeds, as you know, 100 feet is absolutely nothing. And it turned out, despite all the tech that we have in aviation, well, we just saw it again, you've got to think about the human element. We don't know what happened in this crash, but in that near miss, the air traffic controller said I was tired and I just missed it. So we have to remember that despite all the tech we put in, all the safety elements we put in, it comes back to us thinking about the human element and making sure that people can speak up about these mistakes. Because if I go back to the sepsis case here, how many times do you think that case was clearly reported? Out of the 100 times that it happens, how many times do we all think it actually gets reported and intervened upon? I'd argue not nearly enough, if at all. And we'd be challenged to say, how many times is there a discussion with the family as to what went wrong in that case? The discussion often tends to focus on, well, he may have passed away anyways because he was so sick, rather than how could we have prevented missing sepsis. And I see the challenge there, but that's where, those are the cultural pieces we need to get to. And I'll tie it up here and leave some time for discussion here. I think that achieving clinical excellence in quality and safety remains an imperative. And it's one of the nice things about working at academic centers like this one. These places want to be the best, and they want to show that they're the best because they take pride in the clinical care, not just the tech advancement and the research advancement, but in the clinical care. And I think it remains an imperative in healthcare. The inventions we've seen to date are not as resilient as I think they need to be, but we have a lot to be hopeful about because, again, the attention is there, and I think the backing is there. The way forward goes back to the cultural change that I talked about. We've got to get back to making sure that we're talking to our patients. If we focus on talking to our patients about their outcomes, all the other cultural pieces get forced to follow. Better systems of measurement. I think AI is going to get us there with regard to automating how we do measurement. And of course, interventions that make work easier. So what I didn't talk about, and I should mention, so I mentioned the VTE work. In the OR, what we actually plan to first do is to use the video to make life easier for our doctors, right? Once we figure out what surgeries they do and what instruments they need, we're just going to automate making sure their instruments are in the room before the surgery starts. There's no reason you can't automate something like that. And eventually we'll get to the point where if the blood pressure is dropping and people are missing it, we can trigger it for them. Or the other example, we recently had somebody, had a case where somebody needed a medication in the OR, and often we don't do the barcoding there. There's no reason that when somebody pulls out something out of an Omnicell, the computers can't check the medication against the patient's allergies and stop you from giving a medicine to which somebody's allergic. Because that is a weakness that we all have in our procedural areas. The tech can actually make the life easier for our doctors, and that's how we plan to implement, as you can well imagine, to help get the buy-in before we go to more challenging issues of reviewing films and things like that. Although my pushback on that always is, the best athletes in this world, they look at their films to get better, and that's what we should be doing in healthcare as well. So again, as we implement all this tech, just remember, we're all still humans doing our jobs. You've got to keep the eye focused on the cultural and the human element as we move forward on this. With that, I will stop and say thank you. I'm available by email for any questions. And I think I'm supposed to show this code.
was phenomenal and very thought-provoking, and I'm sure we'll have lots of questions from the audience as we want to, sure, in the front. Maybe? Hello?
Thank you. That was a wonderful presentation. Thank you so much for it and for the work that you're doing in this important area. Sure makes me wish I had some of these technologies available when I began my own career in medicine. Quality and safety often are used in the same phrase, but in fact, there are differences between them. There's a human element with quality, as you indicated in your remarks. It goes beyond safety. It involves thinking. I can't help think of a patient I admitted at 1 a.m. in the morning with anasarca. The chart showed progressive congestive heart failure over 2 years in our clinic, but in fact the diagnosis was wrong. The patient had diabetic nephrotic syndrome and suffered needlessly for 2 years. This isn't a system issue, this is a thinking issue. So I could ask many questions, I'll ask this one. Where are we presently in terms of integrating diagnosis and good medical thinking into our definitions and measurements of quality and safety?
Yeah, so you're asking a lot of good questions. So just to get your, so as you know, there are many who believe, and the National Academy of Medicine is with you on this, they actually think diagnostic error is probably the biggest problem when it comes to, when it comes to quality and safety issues. And the first example I gave you was an issue with missing the sepsis, was an issue of diagnostic error. We're still grappling with how to do this, because you can talk about the factors that happen here, right? People are rushed. We know that people are rushed. They may get to the wrong diagnosis. They may not have the absolute right amount of training they need with regard to getting to the right diagnosis. Our focus, what we're trying to do is we're still trying to use tech to help us. What we're trying to do is get the computers, again, in the background to run an analysis so that if the wrong diagnosis is being pursued, to ask the clinician, again, how do you do this? Or to trigger to the clinician, you may want to think about this diagnosis. And that's the approach that we're taking. You know, we're trying to build what we call a diagnostic command center for sepsis. Because we had a case where a young girl came into one of our EDs. She had a perfed appendix and we missed it. She was in RED for 6 hours, went to a different hospital, went to a children's hospital, not in our system, where she sat for 33 hours, where they missed it as well. What we want to do is create an algorithm so that the computer is monitoring and saying, guys, you might be missing sepsis here, or you might be missing an infection here, that swings back to the team and triggers the alert. That's how we're trying to do it. Again, all of this stuff is easier said than done, but that's the road we're trying to go down. Does that make sense? The other place, and I think there was a recent analysis that came out where they had AI read, I think, they gave AI some patient histories, and it did almost as well as the doctors were doing. But we're not there yet ready to turn it all over. But
What about judgment if you have a patient?
Yeah.
Many problems, question of weighing this versus that,
that is the challenge that we have to solve. We have to figure out how do you get that expert level judgment into every case, and that is the nut we're trying to crack. Yeah.
Hi, thanks. Terrific talk. One of the things I wonder about is this, fantastic work you're doing, and it seems like there's almost an arms race again among all the AMCs working separately. Yeah. And why isn't there a consortium where there's rapid sharing of this information to improve patient care in the United States, instead of somebody being able to say, look, we're the best, and we're better than everybody else, versus how we're all working together to improve patient care in the United States with these new processes and technology?
Yeah. You ask a good question. I don't know the answer to that. I think the short answer would be that there's just so much work to be done at home that it is hard for a lot of us to figure out how do we have the additional time to partner together on this. To me, the best example of that I look back at, and I think in line with what you're saying, is that we all bought Epic But if a bunch of AMCs had come together, my guess is we could have built one that was much more clinically focused with the resources that we had. And you could argue that we're making the same kind of mistake here with some of these technologies. So, you've inspired me. There's a bunch of us CMOs and CQOs and other quality leaders that come together periodically. I'm going to go back and propose to them to see if they want to partner on some things like this. And I hear from Dr. Lynch that this system is flush with cash, so I'm hoping there could be some funding to come with it. So, Dr. Fraser.
So at Hopkins and when you were at Brigham in Michigan, how did you facilitate data sharing between the academic medical center and the hospitals and the health systems to provide, more robust investigation, surveillance, and interventions to hardwire safety and quality?
Yeah, so I think a lot of that has to do with philosophy and then how you structure quality and safety programs. So I was lucky in that when I got there, my boss was completely on, as I think I mentioned to you, I 3 days before I had started my job at Hopkins, we had a story break about how 6 kids had died in our children's hospital down in Florida. And our response to that, it was going to be interesting to see how we're going to respond, but we responded with openness, acknowledging that we made a mistake, talking with the families, and driving fixes. And since I've been there, what we have been doing is we convene a system leadership meeting once a month that everyone still comes to my astonishment, that's run by quality and safety. It literally has all the entity presidents, CMOs, CQOs, CNOs, and infection control leads there once a month. We start every meeting with 1 or 2 cases of a disaster that happened in our system somewhere. Real time, not waiting for the investigation to be done. We talked about what harm happened to the patient, and we talk openly about it. There are 60 people on this Zoom call, and everyone is comfortable with the fact that we are going to be open about sharing. So when people see that level of openness of sharing in what we do, the data sharing that happens between our entities and our system and among our entities, it just flows from that. So I actually don't have too many challenges in our data sharing as to how we do this, because we've made it clear that we are going to share. It's not an option.
Thanks, that was terrific. My question has to do more with the human element, because the human element is incredibly complex. I think, if you think back to the old days of M&Ms, they were really exercises in defensiveness and abuse, right? And the conference you just described is one in which I would guess the people who are actually involved are not involved in presenting the case, and you're really talking about the case as a systems issue, not a person issue. But how do you get people who are naturally defensive when an error has been made to get beyond that and buy into this system of improvement?
So 2 things. So you're right. When we talk about the presentation of the cases, the other thing I also should have mentioned that helps with our data sharing, Vicki, is that at the enterprise level, we have a board committee meeting. The cases that we present, 2 to 3 selected cases that are presented by the president of the hospital. They're not allowed to delegate it to anybody else. They have to talk about what happened in that case and what's happening, because we believe that it's that leadership investment that drives the improvement. Now, getting to the question you're getting at, it has to do with what I talked about with the CRP programs. What we have learned is that people do feel, it's hard for them to talk about it, but if you support them through the case, and you're going to take a systems approach in how it happened, it turns out you can get amazing clinician buy-in to move along in terms of trying to advance the discussion in these cases. And that's the way we've done it. Now, in some cases, yes, people are still going to be defensive, but that doesn't stop us from talking about it from a systems perspective. But it's that peer support and that commitment to talking to patients that forces these conversations to occur, if that helps.
I really enjoyed your talk. First question, when you were a law student and you ran the stop sign, did you fix your own ticket?
When I was a law student, did I fight my own
I said,
ticket?
when you ran the stop sign, did you fix your own ticket?
No, unfortunately, I didn't know how, and I still don't know how. And it was in a different state, so I was just forced to pay it. Yeah.
So I think that Rick Boothman from Michigan spoke here over 10 years ago. about the early resolution programs, and I saw that you had data on some Massachusetts programs, but do you have data on how that's been adopted elsewhere broadly in AMCs, and do you have a sense for, are you doing it at Hopkins, and if it's not being adopted, what can be done to, kind of improve that and foster?
So I don't have data on how many AMCs and hospitals are adopting this program, but we will soon have it, again, because everyone's going to be 100% because CMS is going to require it. The bigger challenge in the field is that what we worry about, it's about how well and how faithfully are they adopting these programs becomes the issue. Because a lot of people will say, yes, we have a CRP program, but what they're doing is they're disclosing and talking about the cases only in which it's so obvious that something went wrong, rather than the more subtle cases. And that is the challenge that we're grappling with in the field is, if it's not motivated from within, these programs will never be true to their mission, and that is what we are trying to do. And yes, we are actually implementing at Hopkins, and I'm proud to report that when we started to implement this, we got buy-in from the general counsel of the university, as well as general counsel of our health system, and they will stand right next to me when we talk about how important it is, and this is how we do things here. You need to continue to train your executives on how to do this, because the old school way in healthcare has been when something goes wrong, give it to risk, give it to lawyers, they're managing it. What we're also trying to do is change the paradigm. No, this is a clinical matter when it comes to talking to the patient about what happened in their clinical care and what are the next steps. And they have been amazing partners in driving this forward. And that is what you've got to push towards driving towards. And I'm proud to report that I have not encountered pushback at Hopkins as we try to implement.
We are at the top of the hour, so I think we'll call to a close and thank Dr. Kachalia. Anyone else who has questions, I'm sure can come down.